which some of you may be very familiar with and others less so. So there's two purposes really. One, to go over the general thing that it is for people who've not used it before, but also to update on the changes for the 2021 contract for those who are more familiar. So these are serious mental illness checks, physical health, that we've been doing for several years now. Have we got the slides? That's it, yeah. Next one. So these were mandated to us in the 2016 5-year forward view and have been continued as a major item for the 2019 long-term plan for the NHS. This, as most of you will know, is because of the huge premature mortality gap for people living with serious mental illness, 15 to 20 years, dying younger than they need to, because of very preventable and treatable physical health conditions. So the aim of this service is to expand the physical health checks that we've already got in place, to increase the level of assessment that we're doing and the interventions that we're providing around this. Now, fortunately, oh, I just lost it. Sorry, one moment. Text crisis. Yeah, sorry, okay. So next slide. So we've already been doing these checks for quite a long time, and you can see from this slide that we've been doing quite well across London. This is the 18 to 19 data. The target at that point was 50%, and several of our northwest London boroughs got to this, and there was only 2 other boroughs in London that did. So this is very pleasing. We've still got more work to do with the outer boroughs but in northwest, but they're coming on board as well now. However, NHS England continue to up the game, and the targets are now 60%, with a few extra criteria than before. So the changes this year are predominantly to help us try to achieve those, always trying to simplify the template, make it easier for everyone to follow and know what to do to complete this. So for a basic recap, the key elements of the check. We're aiming to see this group of patients with serious mental illness twice in the year, once for an annual review and once for a follow-up appointment. Now, these were generally expected to be face-to-face, but obviously since COVID, lots more things are being done over the phone, so that is currently an acceptable way to do that. Though it is easier to work with these patients face-to-face, definitely, so it's up to you how you want to play that. Most practices have split these checks into nurse and GP-led aspects, and the template is divided up like that as well, so it's clear who needs to do what. There's quite a lot of physical health metrics to just work through and complete, and the nurses generally do that better than the GPs. We have a tendency to miss things. So for most practices, either the nurses or the HCAs complete those physical metrics, talk to the patients about the basic lifestyle interventions like smoking, cholesterol, diet, that sort of thing. And also, can you make that small? It just gives me it. That's better, sorry. They can also prompt the patients about the national screening programmes. This is something NHS England is very interested in for this group of patients. Their uptake of national screening, such as breast, bowel and cervical, is very low. So they really want us to remind patients what they're eligible for, when to expect to be invited for this, and what's involved, so they're a little bit more aware and more likely to take part in that. But again, the nurses can deal with that very well. We also recommend that they have a blood test, particularly to look at lipids and HbA1c. These are monitored by NHS England. We haven't chosen to make these mandatory in Northwest London because some of the patients, as you'll have experienced, really don't want to have a blood test. and we don't want people to not be able to be paid for the checks just because the patient refused the blood test. However, the more persuasive we can be on the vast majority of patients, the better, because we are expected to hit 60% of the patients having had these bloods. So we would strongly recommend that. The other thing that the nurses can complete is to do an ECG. Most of our practices now offer this for any patient whose Q risk is 20% or more, or is on high-dose antipsychotics. So once you're up at 10 milligrams of olanzapine, 300 plus of quetiapine, that sort of thing, it makes sense to do an ECG every year to check for QT prolongation. This isn't necessary though for all patients. The triggers for this in the template is for the 20%. Okay, so that's the nurse bits. The GP.
Could I just interject something?
Yeah.
Most of the practices don't offer ECG. It's in the hubs.
Oh, is it?
And the patients do need to travel to alternative, for most surgeries, especially the smaller ones, they do need to go to another surgery to have the ECG done, which can be a slight issue for some of them. Just to flag that up, that we're not. Yeah.
Yeah. So I mean, it isn't everybody has to have it done, and you can make a judgment call. You know, if they're sort of on the borderline, or maybe they've had it done with psychiatrists, or maybe it was absolutely fine last year and they're on the same dose, you might choose not to. Okay, so the GP element of the check, this is the recovery and stay well plan, which we'll talk more about in a moment, and also our sort of more objective assessment on the shorter Warwick-Edinburgh mental wellbeing score, which I'll also show you later. The follow-up appointment is designed to be done by the GPs as well, and that's just a sort of check-in to see how they're getting on with the plan that you made at some point previously. There is no specific order. If you happen to see the patient more briefly, you could do the follow-up appointment template first, and then do the main check later once you can get them in for a longer appointment. And it also depends when it comes in the financial year. Both have to be done in a financial year. The order and the time scale doesn't matter. So you could do one a month after the other, just while you're sort of working with that patient. Okay, so specific changes to the contract in 2021. This is all fitted into the new template, which you'll see is a sort of new look, and hopefully easier to follow. The key changes are the addition of a mandatory item for nutritional status, a diet assessment, a physical health activity inquiry, and also a medication review. Now, we didn't really feel that these were massive changes in North West London, given the sort of level of detail that we've already been working with these patients. To be honest, if you're not discussing these elements with them, you probably should be, and most of us would be doing a medication review annually anyway. What's also been added is sort of matching interventions, and these are specified by NHS England, particularly around weight management and exercise, around diabetes, both prevention for patients with the borderline HbA1c and for those who are diabetic who need the structured education programs, and then also for those smoking, drinking excessive alcohol or using substances. But I will come on to those in more detail in the template. Okay, so if you haven't accessed this before, just as a reminder, everything does need to be completed onto the template to be paid for this. The mandatory fields that are for payment are marked in blue, so everybody's aware of those. The template can be accessed under auto consultation, which is towards the top of your screens. You scroll down the list that comes up. Number 11 is mental health. And then as you go to the right, it opens another little list and you go to the yellow one marked enhanced service. And that opens all the templates that we're now going to look at. The advantage of using the templates is that they meet all of our QOF targets, all of the enhanced service targets, and those required by NHS England. So they're all in one place there to make it easier. Okay, so any questions on that before we move on to the actual template? Okay, let me just go back to the slides. Okay, so leaving the follow-up page, which you'll see is the top left tab, starting mainly with the nursing page. This is what we would recommend is done first, preferably before the GP sees the patient, so that the GP can be discussing the findings with the patient there. So at the top, we've got the usual physical metrics, BP, pulse, BMI, height and weight, and then Q risk. Q risk is mandatory. It's one of our minimum data set items, but the second one gives an option for Q risk not appropriate for those patients. I think it's over whatever the age cutoff is, where the Q risk doesn't apply. You just tick that box and that shows that you didn't need to do it. And you'll see on the right-hand side that there's an ECG link there, allowing you to book an ECG link through the hubs if you need to do that for your patient, depending on the Q risk score. Next bit down is for the blood results. This will pull the blood results that you've already got there. You can see when you last did these, any completed fields will show on the right-hand side. You can see it's showing at the moment on our screen the blood pressure, because that's what I clicked on when I took the screenshot. But if you were clicking on HbA1c, it would show you previous HbA1cs, and you could see when the patient's due for those annual blood tests again. So moving on down, we then come to the interventions section of the template. So we've got drop-down boxes for both diabetes prevention programme and the diabetes structured education programme. If the patient declines it, you can tick that as an option, or if they've already done it, maybe they've been diabetic for several years and they went on it several years ago, you can tick that as well, and those all mark that as completed. Just to be very clear, all of these interventions only apply to patients with that condition. So when they're searching our templates to see that we're doing the job that we're supposed to be, they will only be searching to see if diabetes prevention has been marked as done or declined or already completed for patients with an HbA1c of 42 to 47. And likewise for the diabetes HbA1cs. And likewise, as we come on to sort of smokers, that if you're a smoker, you have to do the intervention. And if you mark their diet as poor, you have to do the intervention. So these aren't mandatory for absolutely everybody, only the people that it's appropriate for. So the next little section down is the diet and exercise. I can't open the drop downs, but the dietary assessment, we've kept it simple. It's diet good, average or poor. If it's poor, you're expected to choose one of the interventions, either dietary advice or referral to an appropriate service that we've got locally. Likewise with exercise, you need to click the box exercise history discussed. This is just a slightly weird anomaly in the NHS coding that we had to put a separate box. And then you can use the exercise assessment, which has enjoys moderate, intense or no exercise, which gives more of a grading there. And then following that, the exercise advice as well. And there's always an advice and a referral option for those, so you can tick whichever. If your patient doesn't really want to be referred and says, oh, I couldn't possibly go to that, I'm too busy, you can always just tick an advice option, in which case you say, well, maybe you could think about doing more exercise, etc. So we try to keep it simple, trying to keep it clear, but we would expect this to be completed by the nurses as part of their discussion with the patient. The bit down the bottom where it says under blue for Ealing, this is Ealing expects a physical examination to be done. That doesn't apply to the rest of us. And the bottom line, referral to GP for medication review. This is just something for the nurses to tick, that if they've really picked up on big issues here, say the blood pressure is catastrophically high, they can tick that to say, I did something about it. I told the patient they've got to book to see the doctor to discuss this. Okay, so second nursing page, more of the interventions. Smoking, if the patients are smokers, you should ask about cough and the MRC breathlessness scale, but that's for smokers only. And then onto the drugs and alcohol. These were in our template before, so these are not new for us. They're continues of the same thing. One thing I would stress is we have been being monitored on our interventions for the whole of 1920, and the ones that we particularly miss are alcohol and substance misuse. We're very good at telling the smokers that they've got to quit, but we very rarely do anything about the alcohol and the substance misuse. The alcohol one is triggered for an intervention if you put down an alcohol intake of more than 14 units per week. Again, their advice or referral, so even just telling the patient, perhaps you ought to be thinking about cutting down your drinking. You know, it's a start, maybe a bit of motivational interviewing type questioning to look at where they are in terms of addressing that issue. So the next section is our social questions. These 4, carer status, accommodation, employment and finances, were in the template before. They're unchanged and they have appropriate drop downs to select from. We've added in interventions around social isolation and social intervention. You might want to just click on those to see the options, but again, advice and referral, including referral to social services if need be. These are not mandatory though, so take them or leave them. Below that, in the big orange circle, is a reminder about the screening prompts. We've even tried to helpfully put the ages on so everybody remembers who needs what. We are marked on how many patients in that category are taking up the screening. So we need to tick to say that we've reminded them, and then they'll monitor us by looking at, say, our smears in the 25 to 64 age group of women. They're obviously not going to be looking for smears or for that box to be ticked in men of that age group. So the searches are specific to the appropriate group. Dental and sexual health are obviously good reminders as well, but again, not mandatory. Okay. Any questions on that nursing pages before we move on? Do just put a hand up or chip in if you want to at any point. Is that a question? Yeah. Is there a way to link the ECG to the mental health template? Yeah, I'm not sure about that with the ECG. So there's a question here. Is there a way to link the ECG to the mental health template for patients triggering need for ECG, or will it just be picked up if we've completed the ECG template separately? Yeah, this is a reporting issue. I need to check this with the BI team, I think, actually. Yes, we'll take that one away because that's a good question. I'm not 100% sure. Okay. Okay. All right. So the next page, this is the GP page. So this is the one that the GPs need to be completing. This hasn't changed at all this year. So we've kept it simple for the GPs. 2 main elements to do the Shorter Warwick Edinburgh Wellbeing Scale at the top there. Where I've circled on the right, it reminds you can either just print this off and hand it to the patient if they're with you, or you can pull it up on the screen. And I found it is possible to do this over the phone. If you just tell them what their choices are for the answers, they can you can ask them the question and then they can choose their answer and you can just fill it in for them. It doesn't take very long at all. Let's just go to the next slide. So this is the score, if you haven't seen it before. 7 questions, the patient answers over the last 2 weeks. There's no threshold of score. 70 is most well, 14 is least well, 14 is the minimum. And you see how the patient particularly compared to last year. When you fill it in the little box, you'll see the previous scores, so you can see how well or badly they're doing compared with before. It is very much a patient-rated measure, so it isn't necessarily the answer that you might expect. Some patients who seem really depressed will actually be fairly positive on it, and some people who you think are doing quite well can sometimes be quite negative. So it is about where they're at, and I think compares quite well with how they've been before, which is the important part. And they quite like the feedback to say, oh, look, well, you have, your score has gone up since last time. Okay, I'm just going back one. It's click to, that's the one, yeah. So you'll see the second little circle I've put on. You do have to enter the score on that one for it to record properly. So once you've completed it and it gives you the score, just write it in that box and the previous scores will come up on the right-hand side then. If the patient really can't do this, you're allowed to mark it as not appropriate. The maximum is 10% of your patients on this. And so this is for people who've got a psychotic illness, don't speak English, maybe have a learning disability, and sometimes it's just impossible to translate the thing. Not always. It's quite surprising the people who you can manage to do this with, but it does give you a get out of jail option there. Okay, so scrolling down a bit. A lot of you will be familiar with the 4 boxes on the GP page here. We've had these in for many years now. These were a way to give a bit of structure to the consultation. It can be difficult otherwise to quite know what you're trying to sort of discuss with these patients, and they're not always terribly forthcoming. And bearing in mind, some of them don't have any insight into their condition and don't necessarily acknowledge they've got a mental illness, so you have to tread a bit carefully. But it's useful for us to know what are the signs of them becoming unwell. So how would I know next time they come in and they're not well, is this them becoming psychotic again or not, or is this just having a bad day? What's helped them in the past, the anticipatory care plan. They may say, well, providing I keep taking my meds, I'm fine, but the minute I stop them, I'll end up back in hospital. And they say, well, you know, once I'm going down, there's no stopping me, I end up being sectioned every time. Or maybe I just need to get in touch with my care coordinator and have a little chat and I can sort it out again. So it gives you an idea of how bad things might be and what they might need to get over it. And we're particularly looking to pick these people up early if they're starting to relapse, get in touch with mental health services and do a stitch in time there, rather than waiting for it to get catastrophic, as that's much more traumatizing for the patients. The second half is about patients' goals and priorities. What would they like to change about their life? What do we think would help them move forward? But it is about their choices on this. So they might say, I want to get back to work, or I want to be able to go out more, or to see friends. Thanks. And then we're going to sort of translate what they've said in that into a specific health action plan, and ideally numbering the health action plan comments so that you maybe develop 3 targets for them, like they're going to go out for a walk every day to get out of the house, stop drinking so much, and make sure they take the medication every day. It's really good to tailor these to the physical health plan. So if you've seen that they're morbidly obese, these should generally be about weight management. You might want to put in to go to the diabetes prevention course if that's been something that's been identified and they've never done that before. So it's very, very flexible, which why we've left them as free textbooks. So you can just agree what's important for this patient now. This isn't necessarily what the psychiatrist would be putting in their care plan. Obviously, they're much more focused on the medication and the mental health management. The aim of this is particularly about their physical health care, which can get very neglected. And often that's linked with being able to go out more, do different things. The bottom little section is just the things we have to tick off to get paid. 50% of the patients should have this care plan printed and handed to them. The point is for them to be able to take it away and look at it and remind themselves what they agreed with you that they were going to work on, and that when they come back for the follow-up, you check how it's going and rejig the targets as needed. There are some patients you really, really can't give the care plan to, no matter how carefully worded, and you're able to mark that it's not appropriate or declined if the patient really doesn't want it. Bearing in mind, some of these patients can't read, and that would be a good reason to decline it if you're suspecting that you might not want to put them on the spot with it. So when you've done this page, it's ticking the box, recovery and stay well plan completed. And when the nursing pages and the follow-up has been done as well, you can tick annual review completed. The top QOF box is for the SMI patients, just to show that the QOF check has been done, which is covered by this. And if this is a new depression patient, you can put in the depression review within 56, how many days is it? However many days it is, on QOF has been done there, so that's what that box is for. Okay. Any other questions about this bit? Nothing in the chat. Okay, all right. Let's go on to the next slide then. Sorry,
Anna. So
yeah.
sorry. Did you say 50% should receive the care plan as a minimum? Was it 50?
50, yes. 50.
Thank you. Thank you.
That was a point of negotiation with West London CCG, who wanted more, but we just felt sometimes it just doesn't always feel appropriate. But in an ideal world, giving most of the patients the printout that comes from it, you have to go into, actually go back to that, can we go back to that page? Go back to the fourth page, yeah. When you go to save it, it will automatically take you into the printing off of the care plan. So you can say yes to it then, and then you can edit it. If there's bits you think, oh, I better just take that out and not give that line to the patient, you can edit it from there. And if you really don't want to give it to you, you can just press cancel, and then it stops trying to print the care plan. Same as with all the other care plans that we do. Okay. Oh, actually, one other thought on that. If you find that for some reason you've had to suspend the template in the middle of it, and it doesn't take you to printing your care plan, if you scroll up to the top of this page, if you go along the tabs, along these tabs to the right, past blood monitoring, past detailed meds, one of those further along has a place that says Launch Recovery and Stay Well Plan, and if you click on that, it will take you to the printable version of this template to give it to the patient. So you can always find it again there if you lose it. It took me years to realise that that was there, and it's actually quite helpful. It isn't any good just pressing print when you're on this page. It comes out as rubbish and absolutely minute, and the patient can't see it. Okay, next one. So, next slide. Yes, this one. So the follow-up. So again, this is a free text box. The first big box there that I've circled. You can just write whatever notes you want to write when you're seeing the patient. Most people aren't necessarily inviting the patient formally for this appointment, but doing it on an ad hoc basis when they come in through the year. It just depends how you're getting on with getting those in. The next bit down is about doing this template for any common complex mental illness patients. I'll come on to this in a moment, but basically this is where you can tick to add them into this, to the enhanced service, or if they're much better and don't need it anymore, to remove them again. But we'll talk about those patients in a second. There's the risk section, if you need to complete that. The other new element that has become mandatory now is this mental health medication review. Everybody's meds should be looked at once a year just to check. The psychiatrist may well have done that, in which case you can just tick it off, and you might want to just note meds review done by psychiatrists if they're open to the teams. And we've put in a reminder here. You will find some of these patients are on sodium valproate. It's been a big issue in recent years. Women of reproductive age being on this because of the teratogenicity. So we've added a reminder there, and it's really important to make sure that they've got adequate contraception and it's documented. I audited this in practice once, and it was shocking how few you could find anything in the notes to mention that. So we put the link to contraception if you want to go through that there. The documentation for this has changed now. If the patient is on valproate, is of reproductive age, we would recommend that you refer them into the mental health team for a review of their medication every year to make sure that that's still the most appropriate thing for them. And the psychiatrists have got a template that they have to complete on that to sign it off with the patient, that the patient is signing to say that they're aware of this medication, of the risks of getting pregnant, and that they actually have to sign it to cover ourselves about this issue because it's so important now. Okay. And then just options to discuss with different parts of the mental health team if you needed at the bottom. So not too much to do on this page. Okay, next one. So as some of you will already know, a recall system is really essential to getting to see this patient population. You do need to be persistent. They are very high DNAers. They just often don't feel like coming down. And a lot of them are used to only going to mental health services and not engaging very well with surgeries. And that's what we're trying to change now, getting them used to coming and having physical health stuff done with us. They need longer appointments, either 30 minutes with the GP, or for most people, 20 minutes with the nurse, followed by 20 minutes with the GP. And you can book those appointments on the same day. And then if you speak to them later, you can use that about their results. You can use that as your follow-up. And it's quite efficient then. Having the results is quite a good motivator for attending. The patients are quite keen usually to hear what their results were like. And once they've done it a year or two, you can get them into the habit of attending annually for all of this, so that they sort of know, oh, well, I've got to come back next year, haven't I, doctor, which does help. The hardest is with the first year, when none of them quite know what you mean when you're saying, come in for a mental health check. There is real benefit to recalling these patients, even if you have to chase them several times. Admin can normally do this, phoning them up. Some of them are very hard to reach. Anecdote-wise, my favourite patient ever at Pimlico, it was March and we were dredging the bottom of the barrel of the SMI list for the people that we still hadn't managed to get in despite umpteen invites. And one 60-something-year-old lady finally turned up to see me, who I'd never met before. I was like, oh, okay, schizophrenic. That seemed relatively stable. And it was only when I looked through the notes that I discovered that she'd done 10 years in Broadmoor about 20 years ago for murdering the wife of some bloke she was infatuated with. And I sort of thought, okay, interesting, but I've never met you before. I'm quite glad we got through this SMI list to find you. And actually, over several years of seeing her, we managed to move the focus off, why can't I get off my community treatment order, to actually think about what else she could do with her life and actually rebuilding something after so many years of having been unwell. So it can be quite a rewarding process. Okay, so question, is there a way that we can remove patients from the list if they've had one episode of psychosis and not taking any medication or under the mental health team? Yeah, I'll come to that in just a moment. That's the in remission. Yeah, and so working with this patient group, actually making some changes in their lifestyle, you know, it might feel like an outside possibility, but some of them actually manage to lose some weight and start to exercise more. Some of them, if they're started on medications like olanzapine when they're in hospital, have gained enormous amounts of weight and just have no idea that that's because of their medication and that they need to work at it by exercising. And you know, they are surprisingly open to the possibility of making changes there. So I would really encourage everybody to to feel that there is hope with this patient group. So, which patients are we particularly targeting here? This template is mainly about the serious mental illness patients, i.e. those with psychosis of some description, so usually schizophrenia or bipolar. So we're mainly working off the QOF SMI list, and we have a criteria that 80% of those patients should be seen under the service. It's really important going through that list so you actually pick up on all the people, because there are some very hard to reach people in that group. And it's also worth cleansing the SMI list once in a while, because you find there's people on there who've moved away, and for whatever reason don't need to be seen anymore, and then you're wasting time trying to chase them. Now, as per the question, there is something called the remission criteria. This is in the NHS guidance, but it's very buried, so a lot of people aren't aware of it. If a patient has been 5 years without being an inpatient, without requiring psychiatry secondary care, and without requiring antipsychotics, then you can mark their condition as in remission. So you can Firstly, add it to the problem page. So if you search under the codes for, say, schizophrenia in remission or bipolar in remission, you'll find the code and you just add that to the problem page. Then you need to take them off our enhanced service register. So they will normally have this code, XAJUG, Mental Health Monitoring Administration. This is the code to show that they've been a part of the enhanced service before. You have to find this code in the tab journal, so just search for it and then you mark it in error, and that will remove them out of the enhanced service so that they're not showing up as one of the people who are supposed to be seen under that. So once you've done those 2 steps, they're in remission and you don't have to see them anymore then. Up until this year, we have been paid when we've marked people in remission and done the check anyway, which is a little bit perverse, but it does seem to happen. From this year, they've decided that actually that's slightly unreasonable. So if you mark them in remission and do the check, you won't be paid for that patient. If the patient happens to relapse down the line, as one of mine has quite recently, then you just go on and add that mental health monitoring admin code back in and take off the problem in remission code from the problem page. So the whole thing is reversible in and out as you need to. Okay, next slide. So many of our patients are under community adult rehab team with daily reviews, but very difficult to reach or get in. Is there any tips on what we can do to get them in to say that they're being dealt with already? Yeah, okay. I'll come on to this one. This is on our slides as well. So just before we come to that question, common mental illness patients, within our enhanced service, we are allowed to include some of the common mental illness patients. This is patients with a non-psychotic diagnosis, so pretty much all the other diagnoses, depression, anxiety, OCD, PTSD. Because some of these are extremely unwell, and the ones with very significant functional impairment or taking antipsychotics are well worth seeing under this enhanced service. They can really benefit from it as well. You do still have to see 80% of the SMI population, so it's not about not bothering with the SMI patients and seeing all the perhaps easier CMI patients instead, but you know, if you've got some that you want to add on, that's acceptable. Now, there are some patients who we don't have responsibility for seeing. These are dealt with for their physical health by the Mental Health Trust, so CNWL. That's people who are inpatients, those who are in the first 12 months of secondary care treatment for psychosis, so basically people who are under early intervention, and those who have got a new diagnosis who are not yet stabilised, so whichever is the longer of those two. So officially, the Mental Health Trust should be doing all the checks for those, so we don't have to. In Westminster, we're lucky that we can see their records, so we can see what's going on with them because CNWL is also on System 1. So you should be able to see if the Mental Health Trust has done some of the physical health stuff there. And if you've got patients who are under the mental health team who are particularly difficult to get in, it can be worth liaising with their care coordinator, with the mental health team, and saying, you know, we really need to get this physical health check on this patient. Could you assist them to book the appointment? And sometimes they can send a support worker to even bring the patient to their appointment. And we really want to be working closely with the mental health team so that it's not just a matter of, oh, this is an impossible person to get in, that we work together to make sure that they've got the physical health check done. It is a lot more difficult for the mental health teams to do bloods and ECGs and things, so it's in their interest to work with us on that. So I hope that answers that question a bit there. Next slide. So are there any targets for number of patients on the CCMI list seen? No, because the SMI patients are the priority, the 80% is for them. Any others that you can fit in, manage to do is great. And we haven't put even specific criteria. You use your judgment for the people who you feel would really benefit from that. We have quite a lot of patients who've got a diagnosis of PTSD, who are perhaps on antipsychotics and have some vague psychotic features. And a lot of those are the sort of people that are good to be seeing on this, who are leading very difficult lives. So it's quite flexible, so you can put those people in and be targeted. But obviously the more people of those you put in, the more you've got to, the more work you're making for yourself on top of your 80% of your SMI list. So it's flexible there. Okay, just a quick note on the voluntary and the third sector here. We're trying to work more and more with the voluntary sector, particularly with the mental health patients, using our social prescribers and care navigators. They are able to help patients to book their appointments and come in for the checks. And they can really help us in dealing with the sort of social issues that come up during these checks. So if you're really worried about how someone's managing at home, you might want to just refer them to the care navigator to get a social care assessment done if they need as much as that, or to look at how you can get them involved in community groups, to get them going out more, or a befriender. There's lots of options around there, and they will often have some suggestions for the sort of social issues that perhaps as GPs we're not quite so sure how to deal with. And there is housing and financial support out there as well. Obviously the mental health teams also have access to that, and we're trying to get them all to work much more closely together now, so that this is a sort of seamless service for all the patients, whoever's caring for them. And also so that the patients can move in and out of secondary care as needed without losing access to services because they've been transferred out. And building these resources, making sure that we've got as much as possible available in our communities for all of our patients there. Okay, so just finally, just a couple of things to highlight to you. Sorry, these slides are a bit hellish. These are the data that we get back from NHS England about how we're doing with our SMI checks. Scroll it up a little bit there. These are the main 6 NHS England targets that you can see numbered 1 to 6. You can see on the right-hand side in the blue column how we do on each indicator. This is Central London's data from May this year, so this is literally what we've just been doing. And it's to the year to date, no, actually the 12 months previous to that, so it's showing us how we generally do on each of these items. The one that we're falling down on every time is blood glucose or HbA1c. There's a lot of undiagnosed diabetes out there, yet still we manage not to do the glucose test there. 68% get their lipids done, so they are having a blood test, but we're not adding on HbA1c. So that's a real learning point for us all, I think. You can see it's easy to get a few of these metrics done, but doing all 6 on each of these patients is not so easy. We're down at 43% on the moment on that. Given that the target is 60%, it does need a bit of work, though I think that particularly reflects the COVID situation of late, so that we're all a bit more behind on these things, which is understandable. Using the template is the very best way to get all 6 done. If the nurses go through it, it all gets filled in, and then we've met those targets. They are very, very important for the CCG's reputation. And they're a measure of good work by us with this needy patient group there. As you'll see below, the 3 new targets, which they've been monitoring us on up till now, but have only just aren't yet mandatory, but will be mandatory quite soon by next year. We're not bad at medicines reviews. We're not even bad at substance misuse, because that's been on our template for a long time, but we're not great at asking about diet and physical exercise, which again, you'd think was pretty primary, 34% on that. So that's another one that we just need to work at a little bit. Next slide. In terms of the interventions that we do, we could do a lot more with weight management and blood pressure. They are noting when we put these patients onto both statins and antihypertensives. They pull that from our prescribing data. So we need to make sure we're actually treating these people, that we do follow up on the readings that we get for them. So that's the advantage of them seeing the nurse before the GP, so we can actually act on their high blood pressure. And then the other 2 that you can see are much lower. We're great at the smoking, and it's the alcohol and substance interventions that we're just not doing quite so well. Now, maybe we all have those conversations and don't tick the boxes, but we're trying to make the boxes easy now for us. So those are maybe something to discuss with the nurses. And then the last one, the national screening programmes. We're great with the bowel screening. There's good uptake on those. Cervical screening, not brilliant, and breast screening is the worst. I have no idea why that is, but that's obviously the one that we need to be promoting to this patient population. Okay, I think that's, let's check. Yep. So should we just go back to the screen so we can see if anybody's got questions or discussions points at all? Do put them in the chat or just chip in now if that's easier. Is that a question there? Yeah. CCMI, there was a limit of 10% on patients on our depression register for them. Has that limit been taken out and we get paid for any number of CCMI patients on our list? Yeah, I think this was a locally applied target. Each PCN was able to set how they wanted to split the money that comes. They basically get the funding for these enhanced mental health service checks into the PCN, and it's up to them how they divvy it up. So, I mean, that was a way that PCNs were just saying, well, you can't put too many of those in. So I think that probably still applies locally at 10% there. Any other questions there at all? So hopefully people will find it's not too dramatically different, the templates to before. There's not a great deal that's been added in other than being more specific about these interventions and then the exercise and diet questions. It shouldn't be very much change for the GPs at all. Maybe it's worth having a conversation with your nurses, making sure that they're aware of the things that look different there. And by spreading it over 2 pages, we try to make it look a bit more user-friendly for them. Another question? You mentioned the add remove from CCMI, this box is inferred. Yes, sorry, I forgot to mention about that. So if you're putting a complex common mental illness patient on, it's different to the SMI patients. The SMI patients will automatically be entered into the enhanced services service for the reporting because they're on the SMI register. They're all pulled in anyway. If you want to do this check and be paid for it on a CCMI patient, you have to specifically add them in. Now that's what that box was for on the follow-up page there, for adding the patient. So you say, yeah, this is someone with a very severe depression and PTSD who I want to do the check on. You put added to CCMI, and that means that they'll be coded into the system and you'll get paid for the check. And if they get better and they don't need it anymore, so you don't want to be chased to see that person, then you remove them again. So it's basically a way of putting those CCMA patients in and out of this service, but you don't need to worry about that for the SMIs. I hope that's clear.
As pharmacists, we're doing medications reviews. We look into mental health medication, and we do speak about the patients, about smoking and the misuse. Should we use this template to tick some of the QOF things, or?
Yeah, I mean, anybody can use it basically. So if you're having discussions about those things, please, and it's an SMI patient, please do just tick those off on the template. That would be great. It just helps everybody to be doing this work and show that we've been doing this work. So absolutely, that's great.
Okay. So it doesn't have to be all at once. It hasn't to be done at once. We can do it over stages.
Yes. The whole thing can be done piecemeal if you want to, but bearing in mind it can be difficult to get these patients in. The more you do in one sitting, the better on the whole. But from the reporting point of view, you can do one every day if you really wanted to. And sometimes when you're having a conversation with the patient, they turn up and something's really happened and they're really upset, and you find that you can't get through it all that session, in which case you can just park some of it and do it at a later time. That's absolutely fine.
Thank you.
So, Emma, have you started to call all the patients in routinely now with the corona situation? or are you still doing most on the phone still?
So I've been doing them over the phone still, so they haven't been having the physical metrics yet. We've done all our follow-ups. We've started with that bit, while we were sort of checking in with these patients during the pandemic. I'm just starting to call some of them back in now, because I'm sort of feeling like I'm seeing more patients. And some of them, you just get so much of a better discussion with them face to face. So I think it's just as we gradually become more comfortable with that, and they become comfortable coming in. I mean, to some extent, they're as scared as us, aren't they?
Yeah.
It's tricky. We're early days in the year, but it soon zooms past us, and suddenly we've got a million of these checks to get through. So spreading them through the year is the way forward. They're not something you can suddenly do in March. Any other questions? We're, I think, 4 minutes to 2. What we'll do is share these slides around with everybody, and we'll probably send them out across the whole CCG actually, so people can see them. And the webinar has been recorded, so that'll be made available for people to watch. Any other colleagues who want to see it can watch it there. There is another session booked for a week on Friday, but I think we might, if the recordings come out okay, just direct people to watch the recording. I hope that's okay with everybody. Do feel free to get in touch with me if you've got queries and things not clear. Alison Hope's also quite good with the technicalities, and we refer to the BI team when we need to. And I'll check that other question that we had there. Okay. All right. Thanks very much for listening, everybody.
Thank you
Take
very
care.
much.
Bye-bye.
Bye.
Thank you.